Go ahead and get started. Welcome to our October Knowledge Night event. I'm Ann Lorenz, and I'll be leading the discussion. Our topic tonight, arthritis symptom management. And, okay, Steve, you said this was going to work. Oh, there we go. It's a little bit about me. I am certified as an adult nurse practitioner. Been at the Arthritis Center for about 8 years, I guess. Before that, I worked as an RN primarily in oncology. And as an RN in oncology, we do a lot of education about symptom management, not only the disease process, but the medicines that we used. I really love to do that. I like to kind of problem solve with patients, educate them about their condition and how to do better. Oh, talk louder. Okay. Okay, sorry. And I have special interest in art. I love art and music and literature and beagles. That's my exercise companion over there. Quincy, he's a sweetie. So tonight, our objectives, we'll discuss joint pain and stiffness, treatments that you can use, self-management techniques to deal with joint pain and stiffness. We'll talk about the different types of joint pain. There is a lot of overlap in the different types of joint pain and how they're treated, but there are important differences. And it kind of helps, particularly if you call into the rheumatology nurses with complaints of joint pain and stiffness. There are certain things that they're looking for when you call in and tell them about your symptoms that help them figure out what's going on and how best to treat it. We will talk a little bit about chronic widespread pain, secondary fibromyalgia, if you will. It may accompany different conditions that also cause pain, chronic pain, like rheumatoid arthritis or osteoarthritis. You can get a secondary chronic widespread pain syndrome. The focus is primarily on what you can do yourself to kind of manage your symptoms on a day-to-day basis. Equip you with some ideas, some strategies to manage your symptoms. And I really did quite a bit of research on this, so there will be some research, specific citations through it all. It is a big topic, so I had to trim it down somewhere. Won't talk too much about medications, but primarily self-management information. So our first topic, joint pain and stiffness. Who's had that in the last week? Raise your hands. All right. So again, first it really helps us if we can figure out, not only on the phone if you call in or during an exam office call, what type of joint pain are you having? Many of our patients have more than one type of arthritis, more than one kind of musculoskeletal problem. So we do some kind of strategic question asking, and of course our exam and our labs and all that helps tease it out, whether it's inflammatory joint pain, which would be the inflammatory conditions like rheumatoid arthritis, psoriatic arthritis, lupus, ankylosing spondylitis, that sort of thing. Non-inflammatory joint pain, that is typically osteoarthritis, which is the wear and tear degenerative arthritis that if you're over a certain age, you've got it somewhere. And then damaged joint pain, which that overlaps with pretty much any other kind of arthritis that may have caused some sort of deterioration in the joint itself, so it just doesn't function right, so subsequently it hurts. Then we have to tease out, is it really joint pain, or is it the tissues around the joint, the tendons, the muscles, the bursa, or just kind of that chronic widespread myofascial pain that we call fibromyalgia. And again, it can, or often is, a combination of the above, or many of the above. Oopsie. I'm not a very good clicker. Oh, I bet I skipped. There's one with three. I swear I'm hitting it. He'll hit it once and it'll go. Yes, this is the way it always works. There you go. Okay. So, diagram of just basically to illustrate what I was just talking about. So the one on the left, a normal joint. All of our synovial joints have this kind of bubble thing around them that we call the joint capsule. In a normal joint, there is some fluid in there. It's benign fluid. It doesn't have a lot of inflammatory cells in it. There are, of course, the structures around the joint, the muscles, the tendons, ligaments, and so forth. But when the joint swells, that capsule kind of distends, and you have a joint effusion or swollen joint. In the middle is osteoarthritis, and that is the wear and tear arthritis, sometimes overuse. There's some patients a kind of a strong genetic component to it. But basically, the joint rubs together enough that the cartilage starts to erode, and you end up with the bony surfaces maybe coming into contact with each other. They're not smooth anymore, so you have creaking and cracking and make noise when you move your joints. Sometimes these joints will swell, but again, the fluid is not inflammatory. So just because it's a swollen joint doesn't mean it's inflammatory per se. There was something else I was going to say about this one. Anyway, going on to the rheumatoid arthritis one, that's just one example of the inflammatory joint pain. This one too can cause degradation of the cartilage over time, but the primary process is inflammatory. And see that joint or the capsule is red. That it's inflammatory. There's all kinds of inflammatory chemicals floating around in there. If we pull fluid off of an inflammatory joint, there's a lot of white blood cells in it. There are also the chemicals that we don't test for, but they've been tested for in research, called cytokines. Those are chemicals in the immune system that feed that inflammatory process, so it just becomes this kind of escalating inflammation. And in the inflammatory arthritis, that inflammatory fluid is damaging to the structures in that joint capsule. So you can get degradation of the cartilage, and you can have erosions into the bone. The actual cortex, that outer surface of the bone, could get eaten away in different places. And if that happens a lot, you can get deformities where the joints just obviously are not aligned right. They then subsequently don't function quite right. I kind of think of it like a normal joint's a brand new car that works fine. It goes the way it's supposed to. Osteoarthritis, there's something mechanically the matter with the car. The tires are worn down or whatever. The treads are gone, or the shock absorbers are gone. Just mechanically the car doesn't work right. Whereas in rheumatoid arthritis or inflammatory arthritis, the process within the car is messed up. Not just the mechanics of the car, but it's like the accelerator is just stuck in an on position, and it just keeps accelerating, and it heats up, and it's not functioning well subsequently. So, I just went the wrong way. Okay, we were just talking about computers that. Sorry, that's on tape now. Okay, so these are just pictures of an inflammatory joint, patients that have inflammatory joint symptoms. On the left, the hand of a patient with early rheumatoid arthritis. There's no deformities or anything there yet, or hopefully we can prevent them, but the PIP joints, which are the middle knuckle joints that, like if you knock on our door, it's those joints. Those are obviously swollen. The ones at the base of the hand, where the fingers meet the hand, the MCP joints are swollen. Those joints will be tender to palpation. The joints will be stiff. That patient may have trouble making a fist or getting the joints moving. And then on the right, acute gout. Obviously that first, the big toe is red, it's hot, it's swollen. That would be an exquisitely tender joint. And the ankle is also swollen there. Stephen, I'm going backwards. Okay, maybe by the end of this I will get it figured out. Okay, so on examination, an inflammatory joint will feel boggy. It may look big, but also when we do our joint examination and feel all of the joints, They feel boggy, they're smooshy, and often tender to palpation. Sometimes they're warm, sometimes they're a little red. That's because of that inflammatory process that is going on in that area. The patient will describe pain, but also stiffness that is prolonged. We'll ask, how long does it take for your hands to get kind of loosened up and feeling okay in the morning? They'll say an hour or more. And that's typically an inflammatory symptom. Examples, again, rheumatoid arthritis and so forth. It can flare at different times, sometimes very randomly, sometimes it's after periods of stress where the patient hasn't gotten enough sleep or rest, illness, being off of their disease-modifying medications, that kind of thing. And it's a systemic condition that those inflammatory products are not only present in the joint, they are systemic throughout the body. That's why we can measure them with the blood tests, the SED rate and the CRP, and some of the other labs reflect that systemic inflammation. And in rheumatoid arthritis, ankylosing spondylitis, those particularly we can see, well, and psoriatic, we see other symptoms throughout the body of inflammation. For example, rheumatoid arthritis patients can get nodules, or they can get inflammation in their lungs or their blood vessels, their eyes. So it's very systemic. They're systemically ill when they're having a flare or before they get diagnosed and under treatment. They can have incredible fatigue, malaise, and they just feel really miserable. I swear I'm hitting it. That's what I'm... Maybe you should be the clicker tonight. Okay, non-inflammatory joint pain. Those joints might be big also, but when we examine the joints, say the finger joints, they don't feel boggy. They feel bony. They are enlarged, but it's a hard, bony sensation that we feel when we examine the joints. And sometimes they're tender, sometimes they're not. It just depends. Their joint stiffness is typically under an hour in the morning. Usually, I get in the shower, I get warmed up, I run my hands under warm water. They feel pretty much, better. If it's all-day stiffness, patients that say, it just never gets better. Usually that's a patient with damaged joints. So this would be an example, osteoarthritis, the wear and tear arthritis. It also can flare, but it's kind of, people say, I can tell a weather front is coming in and that kind of thing. They just know that at particular times or with overuse or whatever, they can become more painful for a while. Medications in this are primarily used to treat the symptoms. We don't have anything, unfortunately, yet that besides just protecting the joint, avoiding the damage in the first place, we don't have anything medicine-wise that prevents the damage like we do in most of the inflammatory conditions. Yeah, ow. So, joint pain from damaged joints, obviously these joints would be uncomfortable. The knees, that knee on the right, the bones are enlarged. There's all this excess bone, bony spurs. The angle of the joint is altered. We can do stuff to help this joint, but it's not going to be a normal joint again. So it's basically a matter of figuring out how to work around the symptoms and try to prevent further damage. And the feet, this person I would imagine cannot walk comfortably barefoot. They probably need supports to their shoes and that kind of thing. But obviously the alignment there is off and the joints have been damaged. Okay. Again, that can happen for many different kinds of arthritis, inflammatory or non-inflammatory. Pain results from the improper alignment. The joint just doesn't function right. And subsequently, not only the joint can hurt, but the tissue surrounding the joint may hurt. Kind of mechanical joint pain because just mechanically, like that car that needs I'm not a car person, oil change or whatever cars need. Just functionally, the car doesn't work, and so it does not perform as well. So those joints have decreased mobility, decreased flexibility, reduced range of motion. Often they pop and crack and so forth. Everyday tasks may be difficult, that kind of thing, because the joint isn't normal anymore. This is just an example of some of the questions that we might ask to tease out whether it's inflammatory or non-inflammatory. Does activity help or make it worse? Usually in inflammatory arthritis, activity will help, getting up, getting things moving. And so those patients really do better if they're not idle. Osteoarthritis, certain activities may bother it. So like if you have a lot of arthritis in your low back, walking a long ways at the zoo is not going to be tolerable, and you have to sit down, take rest periods, and so forth. Rest tends to improve those symptoms. And morning stiffness, again, that greater than 60 minutes is typically inflammatory. Less than 60 minutes is typically non-inflammatory. And then this is our job. What do the joints look like? What do they feel like? What do the x-rays show? How is the range of motion? All of that, kind of helps us in our assessments. The distribution of joints helps us to kind of tease that out, particularly with new patients that aren't diagnosed quite yet. Typically with the rheumatoid arthritis, it's the small joints of the hands, the wrists, the ball of the foot, the ankles, and so forth. With osteoarthritis, often it's either joints that get used a lot, like mechanics. They get a lot of arthritis in their hands because they're always gripping things and working with their hands. Knees, hips, low backs, joints that get a lot of wear and tear. And sometimes with the osteoarthritis too, there's a particular kind of osteoarthritis that can affect both sexes but seems to predominate in the women. They can get a really just very aggressive, destructive osteoarthritis of the hands, and that does tend to run in families. Fatigue, the osteoarthritis patients can, of course, have fatigue, but the fatigue with an inflammatory arthritis patient is profound when their condition is active because it's a systemic process. Again, systemic, other areas can be involved, other organs and so forth with the inflammatory symptoms. And cortisone pretty much helps everybody feel better, but the response with an inflammatory condition is often quite dramatic. We'll start a patient who's flaring with RA on a prednisone burst or give them a steroid shot, and they will just feel dramatically better. Say, man, within a couple days, I feel so much better. I'm moving better. I'm not so stiff, and so forth. It helps osteoarthritis, but not quite as much. Okay, so how do we manage the joint pain and stiffness? I'm getting better at this. For inflammatory joint pain, since it is a systemically driven process, we really have to have systemic treatment. And in RA, we call those disease-modifying anti-rheumatic drugs, or DMARDs. There's some examples up there. Many of you probably are familiar with those: methotrexate, leflunomide, plaquenil, the biologics, Xeljanz, which is that tofacitinib. Those actually prevent the damage. So right now, in the world of rheumatoid arthritis literature, the focus is really on early diagnosis within the first 12 weeks and aggressive treatment to get our best chance of obtaining a clinical remission. So not to let people linger on for too long without these disease-modifying drugs, and to increase, kind of optimize it to get our best response that we possibly can early on. And psoriatic arthritis, we use some of those same DMARDs like Enbrel and Remicade and methotrexate. Sometimes we use steroids and non-steroidal anti-inflammatory drugs. Gout is a little bit different. It's more it is a crystalline arthritis. There are actually little crystals in the joint, and sometimes those will flare up and cause an inflammatory response that's extremely painful. In that case, we use the anti-inflammatory medicines, but we also have to target the gout crystals and bring that level down. And then systemic lupus, that also can cause inflammatory joint symptoms. We use Plaquenil or hydroxychloroquine a lot in our lupus patients, methotrexate. Now we have Benlysta, and then sometimes other immunosuppressants, the corticosteroids, and the non-steroidal anti-inflammatory drugs. So we have to target the underlying cause to get real relief and real prevention of damage. Other things, this is kind of more general to all different types of arthritis. Steroid burst is often helpful, again, more helpful for the inflammatory symptoms than the non-inflammatory. Joint aspiration, injection, if it's swollen, it helps to get the fluid off because then it moves better, it feels better, and that can help people get through a flare. Tylenol, of course, over-the-counter acetaminophen. The NSAIDs, which are the non-steroidal anti-inflammatory drugs, ibuprofen, Celebrex, and so forth, those have pain-relieving properties, but also actually decrease inflammation. So they're helpful in both types of arthritis, or all types of arthritis. Sometimes we have to use prescription pain medicines to help people stay functional. Topical pain relievers, there's a whole bunch of them available over the counter, and people sometimes, kind of do a lot of trial and error to see which one they like the best. We have some prescription ones also that are a nice option. However, they can be expensive. Physical or occupational therapy, if you flare with something, often PT is helpful. Occupational therapy is helpful for functional problems like, boy, I just cannot get my shirt buttons buttoned, or I really want to be able to play the piano again. Can you help me get my fingers functional again? That kind of thing. They also have modalities that they use to reduce the pain, reduce the swelling, and reduce your other symptoms. Splinting or bracing to help support a bad joint or a painful joint. If you have bad ankles, an ankle brace with activity is helpful. A back brace, whatever, some sort of external support to a bad joint is often very helpful to decrease symptoms with activity. If you have weight-bearing joint pain, so hip, knee, low back, foot or ankle arthritis, and you are overweight, weight loss can be tremendously helpful. If you think per square inch of, like a little knee joint, if you lose 1 pound of body weight overall, that's 3 pounds per square inch off of your knee. It's amazing. People can lose just 5 pounds, and they already feel that their joints are better. So a weight loss, even just a little bit, can really help. Oh, I thought you said the flaps. Okay, therein lay the problem. Okay, heat or cold. A lot of people have kind of, tried one or the other. Some people really like heat. Some people really like cold. Sometimes alternating the two. In general, for stiff joints, heat is better. Just get them kind of loosened up. Warm water, hot shower, heating pad. For hand pain or foot pain, you can use those hot wax paraffin baths. Heat it up, stick your hands in. It kind of really seals the heat in there and gets them loosened up. Epsom salts, actually a patient thought of that for me. I was like, oh, hey, I better put that in my talk. So that's a good idea. It also would reduce some swelling. Cold packs, ice packs, that kind of thing. It's good for dulling acute or sharp pain. That's more helpful just because it numbs. Sometimes alternating, and then, trial and error. Figure out which one kind of feels better at the time. Fatigue is a problem because of the systemic nature of most of our inflammatory arthritises. It again, can be pretty profound. The majority of RA patients, at least while they're active, or where the disease is active, are fatigued, as are the lupus patients. It's very, very common with them. There was a study that they looked at, okay, so fatigue and functioning and mood, or well-being. 200 middle-aged RA patients, very diverse sample, and socioeconomic status, very diverse sample in Florida. They measured perceived health impairment, so how impaired do you feel with regard to your health, how satisfied are you with your physical abilities, and do you feel depressed? And they did find a strong correlation, kind of no surprise, but a strong correlation between the physical and psychological symptoms. And obviously, in order to control the fatigue, and secondarily, the depressive symptoms and functional frustrations, we really want to control the underlying disease process, and subsequently the fatigue and all of that gets better with better control of the underlying problem. And typically it really does. Oops, that was me. Okay, so a great way to combat fatigue is exercise. Regular physical exercise benefits in rheumatoid arthritis and really all of the different kinds of arthritis. Improved physical and psychological well-being. It's a natural antidepressant, also a natural anti-anxiety technique. Improved joint health, function, mobility, fewer symptoms, and decreased joint pain. Of course, you maintain your muscle mass as well as balance and agility and all that. Decreased fatigue, and also with the systemic inflammatory conditions, those patients also have an increased cardiovascular risk, so increased risk of heart attacks, strokes, that kind of thing. So with all these benefits, why did they find that 71% of patients with RA are inactive? So what's up with that? Darn it. So this group, Jet and the other two, did a review. I'm not trying that second name. They did a review of 26, large review of articles looking at this. What are the barriers, and I'll get to it in a minute, the facilitators of exercise in a group of RA patients. In all of the studies, pain was listed number one, or perceived pain. Fatigue, reduced mobility, and functional ability was also a biggie, joint stiffness, etc. Also, and this wasn't necessarily in all of the studies, but in various ones, patients just didn't know what to do. You know, I have arthritis, what should I do to exercise, what's safe for me, and so forth. Unclear direction, maybe from healthcare personnel, and that's our fault. We need to be actively helping you figure out what to do exercise-wise with your arthritis, and then fear of doing harm, making it worse. So what were the facilitators or motivators to exercise in RA? Support from instructors, healthcare providers, etc., social support, accountability partners, that kind of thing. The positive physical effects, the patients that did report that they exercised did report reduced joint stiffness, a better mood, and increased strength. And what was really interesting in this story is that many of the factors, the biggies, the pain, the joint stiffness, that were perceived by some as a barrier were actually reported by others as the reward or the benefit from exercise. So is it really a barrier or not? Pain, actually when patients really do exercise, and I presume appropriately, they felt better. Less pain, less stiffness, less fatigue, and improved joint function. So also they noticed that the exercisers versus the non-exercisers had a different way of coping or adjusting to their symptoms and their situation with arthritis. They knew how to adjust their activity level based on what their disease was doing. Was their RA stable, or was it flaring? Times of high fatigue, etc. They showed a high level of self-efficacy, which is basically confidence and knowing, okay, I can figure this out. I know what to do when I run into a bad day, that kind of thing. Those with high efficacy no longer associated arthritis with pain. And exercisers had better efficacy at overcoming the barriers, arthritis-related barriers to physical activity. And it was the same even in those that had severe RA. So self-efficacy, this is just an example of a self-efficacy tool. This isn't a tool that we use in clinic, but I can tell you in conversing with my patients and kind of trying to figure out, what is what is the barrier? How are you feeling about your confidence? Can you kind of work around those barriers? These are the types of questions we might ask, or in some way, shape, or form. How certain are you that you can decrease your joint pain quite a bit? Do you know how to manage it? Do you know what to do? What about how keeping your arthritis from interfering with your sleep? You know, basically, are you equipped? Are you knowledgeable about that? And you know, really, this is one of the reasons I chose this as a topic, because I think it's really important to equip patients so that they know how to manage their symptoms. So, basic principles of exercise for folks with arthritis. Of course, you could check with us, make sure, and your primary doctor, make sure there are no contraindications. Physical therapists are a great source of expertise in this area. Are there any particular exercises that you should not do? For example, if you have really, really bad knee arthritis and you're 50 pounds overweight, no, you should not start a running program or do high-impact jazzercise. That seems like common sense, you know, that one, but some of them aren't quite that obvious. Another principle, the stronger the supporting structures around the joint are, so the muscles, flexibility of the tendons, how healthy those structures around the joint are really does make a difference with joint pain. The stronger that is, the more stable it is, and the less the joint will hurt. Of course, cardiovascular-wise, we want to increase the heart rate, the breathing rate, improve your overall cardiovascular health. Again, low impact is kinder to the joints. There are lots of low impact options. Walking on a flat surface is a good option. Water is a very forgiving medium to exercise in. If you can't walk on land for exercise, walking in water is often a good option. Seated exercises like a stationary bike, new step machine, so forth. If you can't exercise standing up or weight bearing, those are a great option. Ultimately, the goal and what the experts in cardiovascular health say, 30 to 40 minutes most days of the week. However, if you're just starting out, don't start with 30 to 40 minutes. Start out with 5 to 10 minutes. Set a small goal first, and then gradually increase. You can't divide it up in segments. A few minutes in the morning, a few in the evening. If you have an inflammatory arthritis and you're flaring, decrease your intensity. Still move, but don't expect as much of yourself. Decrease your intensity by 25% or so. And I actually have a great example of this. About a year ago, I saw a gal about 50-ish, overweight, and she had really bad arthritis in her knees and her feet and her low back. And so I, was kind of, okay, what are you doing for exercise and stuff? And she, didn't like that question at all. And she just said, well, I can't exercise. I tried, and I just can't. And so, okay, well, what have you tried? And she had actually gone to an exercise class that was, one of those that it's high impact and low impact, and you can kind of do low impact if you need to, or whatever. And she tried the low impact, and even that, it was like a 50-minute class. It was way too much for her, and so she hurt more afterwards. So we kind of talked a bit, and she had access to an exercise bike, a stationary bike. So I'm like, well, why don't you try doing 5 minutes, 3 minutes, 5 minutes, whatever you can tolerate, no tension on the bike. Do that once a day for a week, a few days, and then twice a day, and then increase your time. In her case, I didn't really want her to increase the tension too much on the bike because I didn't want her to stress her knees. But then I saw her like 6 months later, and she was feeling fantastic. She had done that. She came and she was so proud of herself. She's like, Ann, I'm up to 20 minutes and I feel great. My joints don't hurt as much. They're not as stiff. I feel more flexible. She was happier. She was less fatigued. So it is doable, but sometimes you have to kind of get out of the mentality. This is what you're supposed to do to exercise, and kind of think outside of the box, if you will. In general, it's good to warm up a little bit, walk in place, whatever. If you're going to be, getting the heart rate up, you want to kind of ease your body into it. If you're going to do weightlifting, start with the lighter weights, of course. If you have a damaged joint or a flaring joint, you really don't push that. It's okay to not use weights at all. in that case. When you start, a little aching or soreness is normal. If it's prolonged or severe, take it back a notch or two. And again, protect the joints. If you have arthritis in your weight-bearing joints, like the hip, knee, ankle, foot, walking on the flat surface is generally better and better tolerated. So for example, if you have a treadmill, you don't have to put the little incline on it. It might bother your knees and your hips. Well-cushioned supportive shoes. If you need inserts, like that guy in the picture of the feet a little while ago, that person would really need inserts to basically support those joints. They do have to be updated regularly, certainly. Pay attention to pain. If it's really hurting, stop and kind of reassess. That's when getting a physical therapist involved is really quite helpful. Avoid movements that twist the joints. I found that out in a Zumba class and got a swollen knee. Braces or supports again, compressive wrap around a joint, splints, that kind of thing to support a bad joint so that you can exercise. And then once the joints are warmed up and your heart rate's up and you're kind of got a little sweat going, it's good to stretch. That's the best time to stretch. It avoids injury and then, of course, helps with your flexibility. So there's some happy exercisers. Okay, so exercise, that's a biggie in symptom management. What else can you do? Complementary and alternative medicine. This is a diverse group of techniques and therapies, kind of not mainstream. They're add-on therapies, particularly with the inflammatory arthritis patients, because for them, they need that treatment that gets to the root of the systemic problem. Sometimes it's called integrative medicine, and we do have a couple integrative medicine doctors here in town. They do things like acupuncture, massage, that kind of thing. Unfortunately, we don't have a lot of scientific evidence to support it. There's some, but they tend to be a little smaller studies in that. My advice to patients with these is usually go with a legitimate, provider that has a good reputation and isn't just, in town for the day to take everybody's money kind of thing. And if it doesn't help or if it hurts, save your money and don't continue. Oops. Okay, so these are some of the therapies: massage, acupuncture, acupressure, gentle chiropractic. We tend to not like the ones that really pop your joints a lot. Aromatherapy and essential oils. Reflexology, which is there's practitioners that apply pressure to certain areas of the hands or the feet to affect other areas of the body. Hey, if it helps and you're with a good practitioner, I would say go for it. Again, small studies have shown some benefit in arthritis, pain, and fatigue. And then there are cognitive behavioral therapies. These are usually done by a psychologist, clinical psychologist, and basically to reframe in your mind kind of your response to pain, coping strategies, and that kind of thing. It actually has incredibly strong evidence in the literature, not only with rheumatoid arthritis, with lupus and fibromyalgia and many other chronic medical conditions, that it is very beneficial. And I think really this is underused. So for RA, there was a study in this Journal of Pain Research, recent study, looking at a bunch of studies, review of many studies. And they did find that a variety of strategies were used to help patients with chronic symptoms identify and change unhelpful patterns and behaviors and attitudes toward their illness, help them adjust to illness, particularly a chronic illness or conditions such as pain. In RA, it was found to be level 1 evidence, which in the world of research, that's the highest proof or the highest level of evidence that it is very legitimate, very effective. In the RA patients, it was most helpful if instituted in the first 2 years, and that's probably before people develop any of those bad coping strategies. In one of the studies that they included in this study, another sharp study, they looked at early RA patients within the first 2 years of RA diagnosis. They all had the routine medical management as well. Half of them received 8 weeks of cognitive behavioral therapy, half of them did not. Then they looked at them in 5 years. They added up their healthcare expenditures, and the ones who had the cognitive behavioral therapy actually used less healthcare dollars, or fewer healthcare dollars. So they knew how to manage things, knew how to cope with things, and therefore did not require as many healthcare interventions. So elements of cognitive behavioral therapy, these are just examples: relaxation training, goal setting, pacing of activities, problem solving, kind of like what we talked about with the exercise, assertiveness training. Saying no sometimes is the best thing that you can do. How to manage flares, restructuring non-helpful cognitive beliefs. Sometimes people kind of catastrophize and say, oh, I feel bad today, therefore I'm just always gonna feel terrible. And that can kind of feed on itself, and it can actually increase their symptoms. So it kind of targets that kind of thing. Distraction is a great pain management technique. Kind of not mind over matter, but at least getting your mind off of the pain or off of the symptom for a while, doing something that you enjoy. Mindfulness, that again helps with the catastrophizing mindset. All of those things increase that self-efficacy. Yes, I do know how to manage my condition. Yes, I have the tools and the knowledge I need to manage my symptoms. This traditionally has been done on an individual basis with a psychologist, but there also have been studies looking at group CBT, online CBT. It's not sitting on a couch in a psychiatrist's office and being analyzed from day one of your life. This is very very aimed at coping strategies. What do we do from today going forward? So it is a counselor, but it's not, maybe it doesn't have the stigma that some people associate with that. So we get asked about supplements for inflammation. And I know the glucosamine chondroitin supplement, Dr. Chatwell did a very good review of that particular supplement in osteoarthritis at his Knowledge Night talk. It is available online. You can there's a YouTube video, and you can listen to his talk that way. Typically with the supplements, it's small studies. We don't have a lot of evidence on them. Some of them have some anti-inflammatory properties, like the turmeric, cumin, tart cherry. There are some studies that show it reduces gout inflammation. Does not reduce the uric acid level, but it can reduce inflammation. Fish oils have anti-inflammatory properties, and there is some question, maybe it helps the RA medicines work even better. Ginger root may be similar to the NSAIDs, like ibuprofen, Celebrex, in effect. Again, go with something legitimate, something, a good traditional brand, not something that you just found at, Mexico or something. Sorry. Just something that's very, a well-established company, and check with your provider, make sure it's okay. It's also a good idea to check with your pharmacist to make sure there's no drug-drug interactions between the supplement and your traditional medications. And again, if it doesn't help, if you take it for a month or so, and you really don't see any benefit, save your money and discontinue it, just like we would stop an RA medicine if it wasn't helpful. So myofascial pain, I heard absolutely everywhere. It's not just my joints, it's my muscles, it's just everywhere. Every part of my body is achy and painful. This can be kind of a syndrome that happens when patients are not sleeping well, they're in pain from something else, say widespread osteoarthritis, and they develop this kind of secondary myofascial pain. And we do treat that in some ways same and in some ways different. Again, often associated with poor sleep, kind of cause and effect. Poor sleep causes this, but also This obviously can cause poor sleep because you're just so uncomfortable. You can have some muscle stiffness, muscle pain, joint stiffness, joint pain. Not always inflammatory, just because the joints, they just hurt. It's thought to be, or the current literature indicates that it's a central nervous system neurochemical process between the peripheral nervous system and the brain, and there's abnormal pain processing. Again, may coexist in patients that have other chronic medical illnesses that cause pain. We use medicines and non-medicine therapy, as we do in pretty much everything else. Symptoms can wax and wane, sometimes flare when everything else is flaring, or if you're overtired, that kind of thing. Patients with this really do better if they stay active, they actively develop that good self-efficacy and stay on it. It often takes some trial and error to kind of figure out what works for them. And sometimes with the medication, it takes a little bit of trial and error. So some things that we know from the literature that do help myofascial pain, that aerobic exercise, it really is in every study that you read about myofascial pain, aerobic exercise it's there. It is listed as a highly effective treatment. Those complementary and alternative treatments, the cognitive behavioral therapy helps, good sleep hygiene habits, have a nice dark room that's cool and comfortable, go to bed the same time, wake up the same time, that kind of thing. The medications for this type of pain are different than, say, the DMARD medicines or any of the other ones. Sometimes they're added on to those in those patients, but they target that abnormal pain processing in the central nervous system. Those are just some examples there. There is one pain medicine called tramadol. It's a centrally acting synthetic opioid, and it also works on some of those neurotransmitters, and it is recognized as effective for myofascial pain. The opiates, so things like hydrocodone, morphine, those types of medicine, really are not recommended, particularly for myofascial pain. They don't work. They do not work long term, and the risks for that outweigh the benefit. Of course, some of these patients, if they have chronic pain from something else plus this, they may be on one of those for the other pain, but specifically for this, we do not use the opiates. So what are the take-homes? Keep moving. I kind of hammered the exercise thing, but just that everybody can, if you need ideas, if you need help figuring out what you can and can't do, what's realistic for you, talk to us, talk to your provider. Our rheumatology nurses are very well versed in all of this stuff, and they can help kind of problem solve it through it with you. Be aware that sometimes it takes some trial and error, various strategies, not just the medicine, not just exercise, not just relaxation techniques. It often takes a variety of things to get your optimal benefit. The inflammatory conditions require the specific medications that target the systemic inflammatory problem. And many patients have more than one problem. So we, kind of develop a regimen for them that works to achieve symptom control in all of those areas, and there is overlap. And please ask us. That's what tonight is all about, and really that's what your visits with your rheumatology provider can be about. Unfortunately, sometimes we don't have as much time as we would like to have, and that's why I chose this for tonight. But let us help you figure out what works for you, what doesn't work, and what you've tried, haven't tried, and maybe ideas for other things to try and do. So I think, and then I just have a couple pages of references. So that is it. So I'll open it to questions. Oh, sorry. That's okay. That's okay. And I think I turn this off. Does anyone?